Oh, we'll close these out actually. Okay. Okay, so we're gonna do kidney and renal, all that fun stuff here. Again, we're gonna focus on the most important aspects of everything. But I will try to touch a little bit more on dialysis and all that stuff, just because Miss Brooks said you guys actually went over it in pretty good detail on her lecture, and she wanted us to kind of hammer that part down. So we'll kind of talk about again the most important stuff that there is with it. And kidneys have a lot of stuff going on with them, but we'll try to break it down as much as we can. And I'm sure there's going to be a lot of you that have had patients with kidney issues, and you've probably noticed a lot of patterns that go along with it all. As per always, on the outlines, the yellow is the most important stuff for the class. The little teal, green blue color is like for extra info. That's there if you like patho and you need it to help you remember, but it's not required for class. Okay, so right here, the main thing to note about kidneys, this is for fun information, but it's about that the kidneys are very affected by perfusion, and this is something that we've tried to emphasize kind of throughout all of your tutoring sessions is perfusions affect, the heart, it's going to affect the kidneys, and it's going to affect a lot of your organs because they all rely, of course, on having good blood flow, good exchange of O2 and all that. But your kidneys in particular, as we talked about in shock, really require to have good perfusion. You can see that too. Your kidneys, for some reason, need a higher amount of cardiac output than your brain does, which is interesting. But the main thing you'll see is that your kidneys are going to be affected by people having unmanaged hypertension because that means that all of that pressure is preventing good perfusion to getting to your kidneys. People who are constantly like dehydrated, things like that. People with diabetes, they have impaired perfusion, like we know, and that can then impact the effect of the kidneys to do their job. Uh, in general, a lot of the same stuff that we think about when it comes to heart health can apply to kidney health. So we see hypertension, diabetes, hyperlipidemia, all of like the classic stuff, as well as things such as alcohol, even like smoking, because smoking impacts your perfusion and increases your blood pressure and stuff like that. All of those can have an impact on perfusion, and anything that has an impact on perfusion is going to have an impact on your kidneys. Like we talked about like 2 weeks ago, I think it was, liver and the kidneys kind of play a role together. Here is something that might provide a little bit of context why that is the case, but again, it is not something that you have to know. Just kind of know that your liver and kidneys can have an effect on each other if one of them is not working properly. And I believe it's theorized that it's due to kind of like the way the RAS system functions. If you guys remember the RAS system from 212, it is the system that leads to the release of your renin. Second. Gets to the release of your renin, which has an impact on the aldosterone, and the aldosterone has all these things on electrolytes and water. So at the end of the day, the end result of RAS system is you release aldosterone, you retain sodium, you get rid of potassium, and because water follows salt, you also retain water. And it's all in an effort for you to keep your perfusion going because you're holding on to fluid and volume. But again, just for context, but part of that whole system involves the liver. So the kidneys release this, which goes to the liver to another part of the whole system. So again, all extra context, you don't have to know it, just kind of know liver and kidneys go together. They can have an impact on each other. And then in general, heart and kidneys can have an impact on each other because it's all perfusion. Okay. So just review of the function of the kidneys, we know that the kidneys are helping to regulate circulating volume. So when you have those patients with kidney issues, you'll see that you'll have these patients that are on a ton of antihypertensives. These people will be on at least like two antihypertensives. It's not uncommon to see like four or more medications for high blood pressure. And some of the ways that the kidneys does this, like I mentioned, the RAS system. So, like I said, we have the retaining of sodium and the release of potassium, which also leads to the retaining of water. So this is what's probably the most important thing to remember when it comes to this. That's how it works on that small scale of it trying to be a compensatory factor. The way it's going to work as like a more chronic long-term thing, you'll see how there is a little bit of difference in it. But that's kind of like the main idea. This is pretty obvious here, but the way that the kidneys are getting rid of electrolytes, the way that the kidneys are going to um, remove some of the stuff it doesn't need, it's going to be through urine. So can you guys tell me when the kidneys are abnormal, taking into account all of this stuff here, what do you probably expect? Just you can just list some things. And we talked about a little bit of it, but what are some things you guys can think about that when your kidneys are abnormal, we're going to have issues in regards to volume? Yeah, so we're going to have potentially low urinary output. So if we're not peeing it out, where's that fluid staying? Yeah, so we're going to have FBO, fluid volume overload. And just keep in mind that just because someone has kidney problems doesn't mean that they're not going to make urine. So, for example, people with ESRD, there's a lot of them with end-stage renal disease that don't make urine, but it's not a guarantee. And there are people with ESRD that can still make urine. So that is important to not brush off. And if you don't have any information about it on the chart, you just talk to the patient and ask them, do you produce urine? Because this could be important for you to kind of see how their part of the way how their um, F&E status is, their intake and output, because maybe you have a patient that has end-stage renal disease. If you make the assumption that they don't make urine, um, you could miss something. You could miss like them having some sort of decompensatory factor. For example, going into shock. Going into shock, you have reduced urinary output. Let's say they are able to produce some urine, and because you assume that they don't make urine at all and you see no urine, you just kind of say, okay, that's normal. And then you miss the fact that they were actually going into shock or something like that. Right? So it's always good to not make assumptions on that case. Metabolic acidosis, yeah. So that's going to be something else that can occur. I'll put that acid-base imbalance. If you guys recall, then ADH, this is antidiuretic hormone. So this is another thing that your kidneys help to regulate is your antidiuretic hormone. So based off the name, this one, well, rather than help regulate, it's something that your kidneys respond to. So antidiuretic hormone, I think your pituitary gland makes it or something. But the main thing, just as in the name, it stops diuresis. So this allows for reabsorption of water. And it does so by affecting the renal tubules. You don't really need to know too much about all that. Just kind of know ADH, reabsorption of water. That's pretty much it. And utilizing the whole RAS system, the response to ADH, that is how your kidneys, and using urine, that is how your kidneys are able to reabsorb water and electrolytes as needed. So this is how the kidneys are able to make all of that work. And again, they are going to filter all the waste. They're going to filter electrolytes, fluids, medications that have been acted upon by the liver into urine. And as kidney function decreases, just like you guys mentioned, we also have a buildup of things in the body. So we have a buildup of urea. So that's where that increased BUN comes into play. Although again, something that we've talked about before is that your BUN is a lot more sensitive than your creatinine. So if you see your BUN being high but creatinine being normal, it could just mean that they are dehydrated rather than something is happening directly with the kidneys. But it is an effect that occurs. So electrolyte imbalances, and we'll talk about specifics on that, and then the drug's toxicity. Okay. So far, so good. Everything makes sense so far. So if kidneys are uh, impaired, we're going to have issues with perfusion and circulation, issues creating urine, issues with electrolytes, issues with drug metabolism, all that stuff. Okay. So we also have vitamin D regulation. Um, the main thing about it here is you don't really have to directly know about the whole vitamin D function and all that stuff. The main thing is here to provide the context of how it affects calcium because that's going to be one of the electrolytes that we learn is affected by impaired kidneys. So your kidneys are there to help activate vitamin D. There's different types of vitamin D. There's inactivated and activated. But this activated vitamin D is what allows for proper absorption of calcium. And therefore, when this is impaired, we are going to have issues with bones and things like that. So, for example, we are going to see things such as osteoporosis, oops, fractures, and things like that. But this is things you can just kind of put to mind when we go to talk about electrolytes in general. So this is what I definitely want you guys to be able to kind of have a good idea about. So these are the electrolytes that we're going to focus on. So tell me what happens to potassium when the kidneys are impaired. Up, down, what happens? Nothing. It's going to go up. So it's going to be, you're going to have hyperkalemia. Yes, and this is due to improper inability to waste it because you're not making as much urine. Your kidneys, can affect your volume, and their kidneys not working means they're not really secreted, and so you're not making as much urine. It's how your kidneys are having a hard time putting like concentrating the urine and doing all this stuff. So potassium is going to stay in your body instead of being secreted. Okay, what about phosphate? Up or down? It's going to go up as well. Yes, so we're going to have hyperphosphatemia, again, due to inability to waste. So your kidneys are very much in charge of potassium and phosphate. So what are some things that occur when your potassium is high? Or yeah, in this case, yes. So what are some risks? And what is your normal range? 3.5 to 5.0. So what happens when potassium high? Risk of arrhythmias. Perfect. Tall, yes, I like that. Peak T waves, what they call that. Awesome. So signs and symptoms include, yes, muscle weakness, cramping, twitching. nausea, vomiting, diarrhea as well. Nausea, vomiting, diarrhea, arrhythmias, yes. Arrhythmias, and let's see, I would include, I would also include here because muscle weakness, your diaphragm is a is a muscle, so consider effect of muscle weakness on diaphragm, and breathing. Okay, but that's good. That's pretty much it. That's the one you're gonna potassium, and of course your sodium is always like the stuff you really hyper focus in on in nursing school. So knowing all the specifics about it is going to be more important than knowing like the hyper specifics of some of the lesser ones. But with phosphate, what do you guys know about it? What's like your main thing with high phosphate? Sure, it has like an opposite with calcium. Okay. Uh, sure. Because of that, then that kind of indirectly does that. Sure. What about any effects on the heart? Any effects on the heart that we know of? No need to be too specific. So just kind of like a way to really cluster stuff down. I would always think of stuff like phosphate, um, kind of leading to issues with arrhythmias as well. So hyperphosphatemia, risk of arrhythmias. That's going to be how most of these play out. I'll provide a normal range, but I don't think you have to, I definitely don't think you have to memorize it at all. This is this is a common thing here. I'll make it teal because you don't need to know it. This one I would 100% know it. Okay. Magnesium up or down? Also goes up. So hypermagnesemia. Magnesemia. That's spelled wrong. Magnesemia. Okay. Again, same rationale here. The main thing you have to know about it, again, is just the same thing. Risk of arrhythmias. We can really cluster a lot of these electrolytes as causing stuff with that. And there's gonna be more detailed stuff. You don't really have to know it. There's an approximate. Nothing too crazy there. What about calcium? Up or down? Yeah, it's gonna be decreased. So this is one where it's kind of interesting. So when it comes to your um this, I'm gonna say decreased, and this is decreased due to part of the reason is due to your high phosphate count because I meant to have like an opposite relationship. You also have the lack of activation of vitamin D, and also potentially due to low albumin levels. So end all be all is that calcium can be decreased. Um, I would say one of the reasons I didn't write hypocalcemia, but as opposed to like the other ones, is just because calcium is a little interesting in that you could have a lab value. So essentially, the way to think of that is BMP. Your BMP will assess the concentration of calcium in blood, whether it is biologically active or not. And this is again extra info that you don't need to know, but what this essentially means is that your body has like calcium that it needs to have for biological process, like a biological use, but it will also have calcium that is not in use. And usually, calcium not in use is bound to albumin. So essentially, you can think of it like your body has calcium that's free, just calcium by itself that your body can use when it needs it. But it also has calcium that is not active, not biologically active, and is kind of attached to albumin as a way of storage. So sometimes if you have very low albumin levels, it will, because the blood calcium in a BMP is the amount of free calcium and the amount of bound calcium, it could show up as being low, but the patient won't actually be hypocalcemic because their biologically available calcium is actually normal. And it just looks lower because of the low albumin. Let me know if any of that is confusing. Again, you don't need to know it, but you might have had that come up at some point in clinical, maybe.
Diego, is that the reason that you get the corrected calcium and you correct it with the albumin to get the right
Yes.
number?
Yes, exactly. So
Okay.
this is called the corrected calcium, and there's a formula for it. So it's going to be your calcium in your blood work plus 0.8 of 4 minus your serum albumin. And this is probably more important if you're into like if you're doing like a higher acuity floor or something. Um, but this is what they'll go off because this is the actual biologically available calcium. So somebody could have, and here I'll drop down the normal range of calcium. Normal range of calcium is somewhere from, I've seen like 8.5 or 9 to like 10.5 or 11. So let's just kind of go off this number instead. I think I usually do see 8.5 though. Let me double check though. If you have Miss Fletcher, she likes this. I think she likes this. This will impress her. I'm seeing a lot of 8.5s. That's usually what I see. So usually that's your range. So usually let's say you have a patient with like like a serum calcium of 7.2 or something. Okay. Um, you might think that's low, but then they also have albumin. Remember, your albumin number is the same range as potassium. If you have an albumin of 2.0, if you were to do the formula, 7.2, 7.2 plus 0.8 times 4 minus 2. So that would be, let's see, do the math. 0 0.8 times 2 plus 7.2, you end up with 8.8. So, for example, the nephrologist. So I actually had during preceptorship, we had a patient, literally a kidney patient, and then my nurse called because she was wondering if the doctor wanted him to have calcium replacement because their calcium was like around this range. The doctor said no because their corrected calcium was actually normal. Because he did this formula, because their albumin was low. So they did this formula, and this 8.8 is within range. So, and these numbers were consistent throughout like the last 2 or 3 days. So he didn't feel a need to correct it because it's actually fine. The active calcium was normal, and they didn't have any signs and symptoms. So that's kind of where that came up. Do you need to know any of this? Really, you don't. Not for this class, but it could come up in clinical, and you might look really smart to your teacher or something like that. But yeah, that's the thing. But again, that's not really important. Just know it's decreased. So I'll highlight this, and this part is all. I don't even think you need to know the normal range. All extra info. If you find it cool, then that's nice. Again, it's cool for like clinical, but not necessary for testing or class. But if you're interested in like working in like step down or ICU, it might come up more. Yeah. Okay. But like you guys mentioned before, calcium low, it could equal when it actually is low, can lead to say low calcium could lead to bone pain, bone pain, or pathological fractures, stuff like that. So, um, yeah. And then sodium high or low. Make sure that it's 0.8 times the 4 minus serum albumin. Okay. Yeah, so this is going to be low. So this one we will have delusional hyponatremia due to fluid volume overload. If we recall sodium, because sodium is one of the electrolytes outside the cell, it's the one that's affected the most by fluid shifts. So because these people are going to have fluid volume overload, they're going to have a lot of fluid buildup. It's going to lead to that retention decreasing their sodium counts. So what could go wrong with that? What do you guys remember from this? Review of 212. Yeah, these are all good. These are all good. How about skeletal muscular as well? Yeah. Yes. And a lot of cramping, twitching, all that stuff. I believe also some nausea and vomiting, kind of. And I feel like this one also causes diarrhea as well, but not really too important to know that specific on that. Just kind of the general gist. And it does have levels, and I think we'll go over a little bit more about this on week 7. That's when you guys will go over endocrine, and a part of those diseases are two diseases mainly that go over a lot of fluid balance stuff. So You have SIADH, which is too much antidiuretic hormone, so you have severe fluid volume overload, and because of that, you end up having dilutional hyponatremia again. So it's always good to like cluster this kind of stuff here instead of like hard memorizing renal as this, and that. You can kind of try to cluster it a bit as fluid volume overload, and that helps you remember the sodium. And then you can apply fluid volume overload to other things, and remember that that causes the hyponatremia. And then perfusion, you just cluster kidney stuff as perfusion. That way you can kind of have that general idea, because that's just kind of it's a bit more realistic to, I guess, like how you can expect real life to be. Just how different, like you don't have the brain capacity to really hard remember absolutely every detail, so you have to do, clustering to really help you recall things, and breaking it down to concepts, I think helps a lot. But that's pretty much it. You guys got everything here pretty well. So then we're gonna go over like your pH and stuff. We already talked about how it's acid-base imbalance, and stuff like that. Your kidneys help to regulate H plus kind of being your, yeah. So let me let me drop down the normal range. So normal range is 135 to 145. So let me do it kind of like this. So what I mean by this is that you kind of have like the general idea how like changes in your potassium are more critical than changes to your sodium. So like someone with like 134, 133, they're fine. They're probably gonna have no negative things, but someone with like 5.2 potassium you're more worried about, and you want to get things done to make sure it doesn't impact, just because there is more wiggle room with the sodium. So you kind of have like a range where you'll have like a bit more minor side effects, and then a range where it becomes way more critical, if that makes sense. So your critical range for potassium is a much smaller range than your critical range for sodium, which has a lot more wiggle room. And here, the 125 is kind of like showing the wiggle room, because you can get this all the way down to here, all the way down to here, before it starts to really do anything. Does that make sense? Before like the really bad stuff starts happening.
Well, I was a little confused because you said at 125 or higher, but the range starts at 135. So I was thinking like, yeah, 145 and higher, but not 125. That's why I was confused.
Oh, my bad. Yeah, this is what I meant. Oops. Yeah, because I guess this was just for hyponatremia. So yeah, good catch though. Makes it more confusing to have it the other way. Does it make sense though? Is all good? All right,
Thank
cool.
you.
Yeah. Okie dokie, artichoke. So yeah, so your urine helps to eliminate some of the, like your kidneys kind of are involved in regulation of bicarbonate, um, which is like a buffer. It helps to keep things more basic. If you guys recall from your ABGs, the bicarb is like the base. Um, and yeah, this is kind of like the H plus is kind of like, it's hard to explain, but it's like the hydrogen particles, and that's kind of where the acidity, quote unquote, comes from. So it does things by eliminating. You could just, it's not scientifically accurate, but you could just think of it like acid factor. That it gets rid of the acid, or it keeps some of it if it needs it. It also gets rid of the base or keeps it to try to manage it. But when this is impaired, what kind of electrolyte acid base imbalance would be caused if your kidneys aren't working and they're having a hard time managing? So for example, yeah, yeah. So for example, like you can do like a, let's just do this. Um, this would be, yeah, let's do this and let's do P bicarb. And let's make this, what would be a good number? Let's just do 16. I don't know. Yeah. Oh, you guys already answered. Yeah. So metabolic acidosis. So just as like a, you see this is acidic. This is a basic. This is acidic. We match. So we match this to this. Bicarb is metabolic. So metabolic acidosis. Would this be, what kind of compensation would this one have? Just spot. Actually, I guess you guys just had your quiz actually, so you don't really need to. You can forget about it. Yeah, partial. Yeah, you guys can forget about ABGs until next semester, I guess. Yeah, cool. Mhm. Oh, good question. Maybe like one. I don't remember if I'm being honest. I forgot finals existed. I'm not gonna lie. Eh. But yeah. So another thing to know is, and I think I want you guys to know this name because it'll come up a bit. You guys remember the name of the hormone that the kidneys make to stimulate red blood cell production? Yeah, erythropoietin. And that's good to know because it comes up um erythropoietin. It comes up a few times on like Kaplan's and stuff, and also medication. If you remember the medication synthetic version of this, it's called Epogen. So kind of knowing the name, recognizing the name is good because it comes up a few times. It's like a fun fact question, comes up a lot. But yeah, chronic anemia. So kidney patients will have chronic anemia. Their hemoglobin could be lower because of this fact right here. And people with kidney issues could be on epogen to help stimulate that. And they would rather have them on epogen if they can, uh, as opposed to just like giving constant blood transfusions. But that also can happen. You can also give them blood transfusions, especially if it's like critically low hemoglobin. But like you guys recall from week one, you just gotta watch out for fluid volume overload if they're getting a bunch of fluid in them. Okay, what else is important? I kind of left it as blank, but honestly, it's really I care more about like interventions and assessment part of it. So we'll just kind of water. We know that obviously we our urine has water, it has electrolytes, it has urea, it has the H plus, like we mentioned, like the acid, and it has creatinine. That is a waste product that your body has no use utilizing. Okay. This is also straight from the PowerPoint. We have things that we should not see in the urine. We should not see blood, hematuria, proteins. Yeah, protein is should not really see proteins, ketones, and glucose. These are not typically found in the urine. So these are things not to have. And then for the diagnostics, you could just go ahead and list every diagnostic that you guys can think of that is relevant to kidneys. So when you guys are in clinical and you're looking at the labs, what on like a kidney patient, what would you kind of write down and keep note of? Okay, sure. Urinalysis. See how much urine is coming out. Sure, specific. Okay, BMP. What about the BMP? I guess we kind of already talked about it, but yeah, BUN creatinine, GFR, pretty much. That's pretty much like the main ones. And eh, I will keep it as BMP. We already talked a lot about electrolytes, so like electrolytes and stuff. Creatinine clearance. Yeah, so I'll talk a little bit more about creatinine clearance. It's not the most common lab you'll see. I'm trying to see what else. So what else could be important? Um, your CBC for like your hemoglobin and stuff. Sure. Yeah, hemoglobin. Uh, uh, pretty much just for the hemoglobin part, honestly. If there's anything else that could be interesting is maybe the MCV, extra info. High is B12 deficiency, low is iron deficiency. Extra info, don't worry about it too much. KUB, so like an assessment on yeah, that'd be good. So kidney, ureter, bladder scan. Sure. So we kind of have electrolytes all here. KUB, I kind of like that just to see if there's anything going on. Sometimes it's called like it's called hydronephrosis. So that's when like let's say someone has a UTI, well, not necessarily has to be from a UTI, but it's essentially when the urine backs up so much it goes all the way up to the ureters and then kind of makes it all the way backed up into the kidneys. Yeah, so KUB is the kidney ultrasound. So KUB is kidneys, ureters, bladder. This is a CT scan. But yeah, and we've kind of talked a lot about all these values and kind of what they mean. So BUN, I would say an estimate of it is like 10 to 20. I don't believe you have to hard memorize it. Just kind of know what's crazy abnormal or not. And we've talked about this so many times. It's just a determinative more of hydration levels. It can be elevated even if you're just dehydrated and have normal kidney function. Your creatinine though, probably closer to this amount, although I've seen different numbers on both ends. But I see this a lot. 0 0.7 to 1.1. I've seen 1.3 and like 1.2, but I think I see this number range the most. And we'll talk about BUN and creatinine ratios a little bit later. Right now, this is just kind of like the general idea. GFR, and keep in mind that you'll probably see eGFR on labs more than anything. E stands for estimated. So this one's kind of like this. But you will typically, because it's an estimate, you won't get an exact number usually. You'll probably see something like above, for a lot of people, you see like above 65 or above 120, above 100. You don't get an exact number. You don't get an exact number. You get like something like that for eGFR. There's also the creatinine clearance. This is your true GFR. This is like an actual GFR. The non-estimate one. This is the one that you'll see be more specific, and this is the one that they will do on people to kind of determine if they need doses adjusted because their kidney function is so low that they need adjustment to their dose, or else it could lead to drug toxicity. And they do this with a 24-hour urine collection. And if you guys recall, you discard first void and then collect from there. Okay. As for the UA or urine output, we have a UA, but there's also like urine output. So eyes and nose, urine output. Then what's the number that they want you to remember? So it's going to be mLs per kilogram per hour. Yeah, like one. I would say 0.5 to 1, like for an adult is like a good estimate. Somewhere around this range is expected. This is how much it should be. Um, and then also this is like an average of how much a day they want. This is like the absolute minimum. And we want urine output. If you recall from like early semesters, they also want like around 60 mLs per hour. This one's more accurate, of course. It's weight based and everything. So this is the one you should remember. And this is like a decent estimate for most people, but going off the weight base is more accurate. So 0.5 is probably like the absolute minimum, and then to closer to 1 is like a more optimal kind of thing. Um, Something else you can consider is probably like the MAP, the mean arterial pressure, because remember that your kidneys really care about your perfusion. So anything perfusion related, your MAP is like a good indicator. Do you guys remember kind of what you're looking for in terms of that? Okay. Yeah, like 60 to 75 minimum. You probably want closer to 70, but yeah, that is like the absolute minimum that you want so that you're not kind of struggling. And you'll see later that it can be used as like one of the criterias for kind of what we'll talk about in a little bit. Minimum, say 210 is ideal. Anything less than 60, at less than 60, the kidney. Okay, what's the formula to calculate it?
I think it's 2 systolic plus 1 diastolic times 3.
Close. It's actually all divided by 3, not times 3, all divided by 3. So we'll go 2 times diastolic plus systolic, and all of it divided by 3. So I'll give you guys some examples and then just calculate it into the chat. So for example, let's take a look at the quote unquote perfect 120 over 80. What do you guys get on the calculator? Yeah, so like around 93. So that's pretty solid. So at um let's take a look at a blood pressure you might see when someone's starting to like decompensate, like 87 over 51. What do you get from there? Yeah, so you can see how that's getting closer and closer to like the bare minimum before they're gonna really start going downhill. So yeah, you guys seems like you guys got that down. So I want you guys to 100% know this, and you're gonna keep knowing this even up until 240 because it will come up again. And just to let you know, um, yeah, don't forget this because in 240 they'll probably like remind you guys that the MAP exists, and then if you don't remember it, you'll just be like, oh, I have to calculate it for this test, and I didn't exactly remember, or so just be ready because this will be something you'll calculate during exams, even in 240. So just keep this in mind the whole time. Okay. Any questions on anything so far before we go into acute kidney injury? So what we went over is kind of some of the general functions of the kidney. So just always remember kidneys and perfusion. Kidneys and perfusion go together. Liver and kidneys kind of go together, like we learned before. Kidneys deal with again, circulating volume, which is perfusion, and it does so by manipulating fluid shifts, getting rid of things through urine, including electrolytes, hence why you're having fluid volume overload because it deals with fluids and electrolytes. Therefore, you have FBO, you have issues with these specific electrolytes and kind of get an idea for what it means for them to be what signs and symptoms comes from them being abnormal, or which ones are high, which ones are low, the effect of acid balance um, that the kidneys have when they're impaired, so metabolic acidosis. Just keep in mind the chronic anemia part of it and have a general understanding of these diagnostics, which I think are things by now that we kind of know just because of clinicals forced us to learn it. So BUN, creatinine, we'll go in a bit more detail. This is an important number to know, so make sure to keep it in mind. And this is important. Okay, again, if you have questions, just write it down and we'll get to it. So now we have, just to see what we have here, we have acute kidney failure. We're going to go down to chronic kidney disease and just talk about dialysis. Okay, so I wrote down the definition of AKI. So rapid decrease in kidney function. The prognosis depends on how bad it is and how soon things are implemented, just like pretty much everything. So there are a few different types. The pre-renal is split into like the three H's. What are those? Okay, hypovolemia. That's one of the three. And not hyponatremia. It's another hypotension. And I know these all sound extremely similar. So I'm going to provide some examples. Or if you guys feel like you have examples of them, just feel free to list them down. Because they are very similar. And honestly, you don't really have to make the hard differentiation between all three of them. Just honestly know the stuff that it incorporates. Don't bother with the semantics of it. So hypovolemia, this is just kind of stuff that can lead to, hypovolemic or hemorrhagic shock. So stuff like trauma, overuse of diuretics, general dehydration, or like severe polyuria. So we're talking about like DKA or the HHNS. Oh, no problem. Yeah, could you guys go over that, huh, today or yesterday? Yesterday, or tomorrow actually. So then hypoperfusion. Again, all of these sound very similar because they are pretty similar, and you don't have to, again, don't have to bother with the semantics of it, just kind of understand the general idea. So this one refers to decrease in cardiac output. So examples of this, yeah, like an MI, congestive heart failure, cardiomyopathy, valve dysfunction, all heart stuff here. So basically stuff that affects heart function. So here you see stuff that affects heart function, stuff that affects fluid stuff. So trauma, losing blood, diuretics, losing fluids, dehydration, losing fluids, losing fluids. Now, hypotension, this one is what we talked about, the MAP less than 60. So examples of this could be hypotension from something like sepsis, where you are going into, for example, like septic shock, burns. Yeah, like that would be kind of like massive fluid shifts, um, and stuff like that. All of these things that are causing the MAP to drop under 60. And there's going to be a lot of these that overlap. Again, don't worry about which one falls under this category versus this category versus this category. Just all these things together. That's what can cause pre-renal. So stuff like that. And yeah, pretty much it. It's also worth noting that for this map less than 60, it also kind of applies into the intrarenal, like we'll talk about in a little bit. But the idea is that this is all stuff that can lead to, um, I would say it's like important stuff that's impeding the function of the kidneys, but it's not permanent at this moment. Intrarenal is when it becomes more permanent, much harder to treat. This is more pronounced kidney damage. So that includes things, or you guys can tell me, what does that include? What are some things you guys can think of that could lead to long-term kidney damage? And that also kind of plays into chronic kidney disease, etc. So sometimes your AKI can go away and then you'll be fine, or it leads to permanent kidney damage. Okay, so we'll say nephrotoxic agents. So that includes antibiotics, some NSAIDs, contrast. So, and certain medications, of course, other medications. So NSAIDs, meds. Okay, what else can cause some permanent damage? Obstruction, say, that's a little bit more of the post-renal. Cancer or trauma, you got blunt trauma. Okay. So I would say this is kind of where they kind of merged together a little bit. So I would say that all that stuff can cause things, but it'd be more like a prolonged sepsis can cause it, just like how it can cause here. So it's more like a prolonged. So this is how I would kind of think of it. So overall, your kidneys function on your MAP. So it's all about kind of that minimum number. So your MAP under 60 is going to cause kidney impairment. And that's going to lead to this kind of like the pre-renal acute kidney injury. There's impairment, but it's not permanent damage. If that stays consistent, and it's worth noting that this MAP under 60 can apply to stuff in here and stuff in here, because over time, if it's kind of constant, it's going to lead to a poor MAP. So the key phrase is just like the prolonged low MAP. So the idea of this, the progression is kind of like pre-renal damage. Now it's intrarenal, which is why when someone has an acute kidney injury, you want to try to treat it right away because you don't want to give them permanent kidney damage. But these are going to be like the main kind of things going on, and things that can cause this are pretty much anything here, which includes sepsis, like you mentioned, includes trauma, like you guys mentioned. So the key thing about this is just kind of like permanent damage, permanent scarring damage from all these things that are toxic to the kidneys, permanent damage from a lack of perfusion for long periods of time, etc., etc. Does that make sense? Any questions on this part right here? No questions? Okay. And someone mentioned it. I think it was Alexis. So mentioned then obstruction. Obstruction is more like the post-renal, uh, kind of like obstruction in the ureters. Leads to the backing up of urine in the kidneys, and this is that hydronephrosis that I mentioned before. So if you have some sort of backing up, okay, cool. Some sort of backing up here, the urine is gonna back up into the ureters, and over time, yeah, like a kidney stone here. Um, even like some sort of other obstruction where it's backing up slowly up here, or like having a kidney stone right here. All of this backs up, and it leads to this hydronephrosis, which can lead to infections and stuff because you have all this waste product just kind of um, sitting around here. So point is obstruction, backing up of urine is going to lead to damage, which is when then it can become intrarenal again. So the names are a little confusing, but they kind of make sense. Intrarenal inside the kidneys. So that's where you have the issue with the kidneys themselves directly. Pre-renal is issues of with stuff that leads to impaired kidney function, but not exactly fully kidney related. Post-renal meaning something that's past the kidneys. So here, this issue here is something the kidneys did their stuff. The stuff surrounding proper kidney function is fine. It's just this obstruction that goes past it that's causing the issue. So that's kind of where the names come from. But again, don't worry too much about semantics. Don't worry about this versus this. Just kind of really understand the key things about it. So intrarenal is permanent damage. All of these things can lead to this, but there's also this right here, which can lead to this. because it directly affects the kidneys. Does that make sense? Questions? So we can say examples include strictures, stones, tumors. Okay. So this is in regards to your BUN creatinine ratio. What do you guys recall from pre-renal versus intrarenal ratios? Yes. So this is, yeah, BUN creatinine. What do you guys remember about the actual physical like number? Yes, that is correct. Yes. So this is a BUN over creatinine of ratio of this, and this is this. So this or more, this or less or lower. So let's actually apply that into stuff. So for example, let's see if I have a good number. Let's say you have a BUN and the creatinine, you have a BUN of, so we said our normal is like 11 to 20-ish. Let's say it's like 32 and our creatinine is somewhere like 0.85. What would the ratio be for this? Yeah. So literally just take 32 divided by 0.85 and you get, I don't think my calculator shows, but you'll get a ratio of like about 37. So 37 is higher than 20, so it's a pre-renal. And that makes sense with what we know about it, right? We know that BUN is an indicator of that you're having some issues with like your ability to get rid of some of the waste, but the creatinine is not abnormal because there's no long-term or even like short-term like direct kidney damage. Like we mentioned before, the creatinine is a better indicator of direct kidney function and damage as opposed to the BUN. Does that make sense? Does that track? Is everyone following so far? Yeah. Okay. Yes. So I'll do one of like the same example. Maybe you can see some of the progression. Um, let's see, and then I'll do one that's going to be intrarenal. So let's say again, same idea. Let's make this guy a little bit worse, a little bit worse off. 40 and then 1.5. So now the creatinine is actually abnormal, but you'll see what the ratio is. So so again, literally just take this 40 divided by this number here. Yeah, so you get like 26 on this one. So that is still in this pre-renal range. So in this case, this is like I said, a worse condition than the last one. The number because the creatinine is now higher than normal, but it's not to such a degree that you have fully like permanent damage. we're not at that intrarenal ratio yet, but we are definitely having a lot worse kidney function. So in the acute phase, having increased creatinine is a sign that now things are getting more serious between like impact to kidney, but it's more of that chronic creatinine being elevated. That's more of a sign of like permanent damage. So even in like an acute case, your kidneys can have elevated creatinine without necessarily meaning that it's permanent damage, but it is a sign that it's a more serious condition. It is honestly not. It's not a reliable indicator per se. So you can have creatinine elevated and then have it go back to normal, and the patient doesn't have permanent kidney damage. It's not the most reliable, but it is an indicator that the kidneys are very impaired because your kidneys will do their best to get rid of creatinine more. Like it will do its absolute best. So it takes a lot for that creatinine to become abnormal because your kidneys will always do their best to get rid of it in whatever way they can. Um, as opposed to like BUN where it's definitely trying to get rid of it, but it doesn't it's not doing like its absolute best to get rid of it. It's doing the effort, but it's not gonna like stress out if it's if it's starting to build up compared to the creatinine. The creatinine it will try to fully get rid of it, which is why dehydration can have BUN go up, but the creatinine can stay the same. So creatinine is a sign that the kidneys are trying extra hard, but them being abnormal doesn't mean it will no longer go back down to normal after the AKI is done, if that makes sense. So it can be a bit hard to tell and it can be pretty vague. For sure, it can be vague. Um, Especially as you can see, like even with this number, we have um we're still in this pre-renal range. For us to get to this intra-renal range, we do kind of have to try pretty hard. So, for example, uh, 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 let's try something like um, let's try 40, but then this is like 4.2. And I know Kaylin has seen creatinine up to like 9, I think. She's seen that creatinine of 9 before. That's when you know it's super bad. So you see from this ratio, it's like 9.5, and this is more likely to be direct kidney damage because we are at this ratio of 10 or less. And you can see from the numbers just how bad it actually has to be to get to that point. Just it being elevated doesn't necessarily mean there's damage. It just means there's a lot of impairment. But when it's this bad to the point that you are at this ratio, it's far more likely that there is direct damage, if that makes sense. You won't really do too much about with the ratios, but it does help to understand the general concept. And I think it's good to apply this to clinical, because I think I think it I think like urine output and like constipation and stuff gets overlooked a lot. But then you get patients that are not being assessed on their eyes and nose, and then they end up getting AKI. And I had a patient actually, not gonna say where, but I had a patient in clinical who was on a Foley catheter. They were nonverbal and stuff, so they couldn't really complain too much for their own self. Um, the nurse didn't want me like worrying about like he didn't want me to look at the eyes and nose. Like he's like he didn't want me to like empty the catheter and like document it. said not to worry about it, basically. And I remember coming back, I got that patient again like 1 or 2 weeks later, and he at that point had an AKI. He got an AKI, and now he has chronic kidney disease. Because I think honestly the guy wasn't checking, and I'm sure that obviously there's multiple nurses that took care of him, but they weren't really focused too much on all that stuff going down. And the guy was not really a complainer because he couldn't talk really. He was very demented and couldn't really even talk. So he just kept quiet, and because they weren't really monitoring him too well, I think all of his stuff went down and he got an AKI and then had permanent damage. So I think it's good to apply it and really do think about your urine output and all that stuff. Um, Try to advocate for maybe like this person maybe needs some fluids, or maybe we need a um, nephrologist consult or something because their numbers are starting to get a little bit off. And there's only so much you can do if there's no orders for fluids, or if all you really have is oral rehydration, and this person is nonverbal, so they can't really complain, but you're seeing the progress of it happening, if that makes sense. Let me know if anything doesn't make sense, because I know this is a little complicated. But that's how this ratio works, and then that's how it's applicable. And I feel like it's good to look at the actual numbers rather than just be like, oh, this is the ratio, because it lets you really see how how much the numbers are, like how bad the numbers get to. Okay. Any questions on this part right here? Okay. Please. Okay. So ah, so this is for you guys to fill out. It's just and we did talk about it like always, but what are some things to assess people that are at risk? So pretty much take everything we talked about and try to apply it. How are you assessing? What are the things you're looking out for? What are the things that put people at risk? Okay, so some labs. Yes. So labs, their eyes and nose. Okay, good.
Daily
What
weight.
daily weights, that could be a good one. Okay. What are some things? So what about some things that could be going on with the patient for you to think about? So for example, what are things that they could be getting that might have an impact on all this stuff here? What's something that affects how much urine?
Contrast.
Contrast, okay. So okay, what else other than contrast, what else is nephrotoxic? Medications, okay. What is an example, like common thing you'll see on the floor all the time that people get that can impact the kidneys?
Antibiotics.
Antibiotics, yes. Antibiotics, NSAIDs, too much NSAIDs, antibiotics. Vancomycin is famously known for being hard on the kidneys. Um, what else? What about something you might not even think about? Let's like heart patient. There's like a common joke is that cardiologists versus nephrologists, they're always going at each other because the cardiologist wants to provide diuretics, and the
Diuretics,
patients,
yeah.
yeah, patients on 1 million diuretics, and that is can damage the kidneys. They're not getting enough fluids. They're on fluid restrictions and diuretics, and you see it very commonly that nurses will just push the diuretics even though the patient's no longer congested. Their lung sounds are clear. They're clearly like shriveled up, and they'll still push the Lasix because it's part of the routine without really thinking about how, like, is it actually necessary at this point? What's their flu, like, how is it affecting their kidneys? Does that make sense? So we talked about nephrotoxic, we talked about the diuretics, we talked about eyes and nose, we talked about urine output. I would also keep in mind, because I had it in hidden color. Boom. MPO status. So if they're MPO, are they getting IB fluids to make up for that? And again, still like eyes and nose and stuff. Surprisingly not included, but yeah. And of course, you're thinking about the three H's again. So all this stuff here that, again, we don't want to hard memorize into these categories, just have an idea. And you can cluster them all together. This is just F and E stuff, heart stuff. Perfusion, general perfusion. MAP is general perfusion. Cardiac output is heart. We know heart deals with perfusion, so it's all general perfusion. Fluid and electrolytes deals with perfusion because it's fluids. Fluids help you with your perfusion. So that's how you really want to cluster it down because it's going to help you as opposed to hard memorizing each little detail. All right, and then here are all your labs that we talked about already. So there was no need for me to like ask for it again. High BUN, high creatinine, high potassium, low sodium, high magnesium, which like we said, try to really just cluster down your phosphate and your magnesium with arrhythmias. Even your calcium can lead to arrhythmias if it's abnormal. Of course, it also comes with like the TEDNI if it's like low. In this case, we have low calcium with kidney patients, so TEDNI. So here's all this stuff we talked about. Phosphorus has that inverse relationship with calcium. So the calcium, think about the bone fractures and the bone pain. The low calcium we talked about. Low RBC, HNH. So think about like anemia and stuff. And the metabolic acidosis, like we talked about prior. And let's see how much more we have left. So now talk about some of that. We actually talked a lot about this. So we talked about the fluid balances, daily weight, strict eyes and nose. So I'll immediately kind of start here. And then what helps? So if you are lacking in fluids, what helps? If your eyes and nose are not looking too good, you're very dehydrated, like a bolus, yeah, like a fluid bolus. So yeah, and this is kind of like a thing that has to do with one of the things they say you can do to try to indicate. So fluid bolus, if it's a pre-renal cause, it can help with your the fluid bolus can immediately like improve your urine output. Um, if that fluid bolus isn't helping, it could be a sign that this is more like permanent kidney damage. So like the fluids don't even help at that point as much because the issue is then with the kidneys processing everything. This one's kind of interesting. It's kind of like a low dose of diuretic. So it's there to try to hopefully stimulate the kidneys, which is kind of ironic. But if you recall, the way, well, we didn't really talk about it, but Lasix works directly on the kidneys. Um, so the idea is that it's kind of like hoping that it would kind of kick the kidneys into working normal again. It like hopefully it stimulates the function of the kidneys. So the diuretic along with some fluids hopefully makes the kidney, it's kind of like a last ditch effort almost. And this is something that I know that they talked about, but I know that they even mentioned it, is that they don't really do this much anymore, which is like the dopamine. Yeah, that's kind of like the idea of it. These are more like your first response is going to be the fluid bolus and hopefully catching it earlier. And then these are like, well, we've done what we can do. Let's just hope this actually helps to stimulate. Trying to see if there's anything else. Any questions on like some of the management? Some of why CCBs? Yes, so calcium channel blockers. Um, so people with kidney issues, they have like the high blood pressure, so that inherently helps with the blood pressure, but it also has an impact on the amount of urine that gets leaked into um, into the urine. So it helps with the proteinuria. So CCB, so calcium channel blockers, and ACE inhibitors as well. So that's why you might see someone with, even though we think about lisinopril, for example, increasing the potassium, which is already something that's happening, it also helps with the proteinuria. Because remember that one of the signs of kidney failure or kidney impairment is that you start to leak albumin, you start to leak protein. So that is the reason for it in particular. Yeah, so as for the patho behind it, I don't really know it too deeply, but it's just in the way it affects the vessels in the kidneys, and the change in the pressure there affects what things are able to um, permeate through versus not. Because if you kind of look at the loop of Henle, let's just kind of take a look at that. The way all this stuff right here looks. Um, you have, if you see all the vessels here, you have all these vessels. They're not actually directly they're not like fully directly connected. So it's stuff permeating through the vessels to to the ducts, to the ducts that make it to the ureters and the bladder. So it's all permeating. So it's all passing through because of the type of oncotic pressure that's built up in here. This is again a lot of extra info you don't need to know at all, but that's kind of how that goes. So the way the calcium channel blockers have that effect on some of the arterioles. So these arterioles here, where uh, where the blood and the proteins and all that stuff, sodium, all that stuff is flowing. It changes the way they're able to permeate through and collect into the urine. Make sense, kind of? Yes, no? Again, you don't need to know the specifics, but that's kind of the rationale. So oliguria, that is low urine output. So the main thing you're looking out for is kind of the stuff we talked about. You're looking for anything less than 0.5 to 1 mLs per kilogram per hour, because that is your base minimum. base minimum urine output that you want, or less than 400 ml in 24 hours. That is kind of what is expected of the oliguric phase. So these are the stages of acute kidney injury. So you start with what you would kind of expect. The oliguric phase, that's that phase where you're not making enough urine because the kidneys took a hit. And again, we're gonna again talk about the interventions here. So you're going to be looking at the BUN creatinine ratio. You're looking out for the 3H's. If you have this 20-1 or more, that's that pre-renal. And we mentioned already, we're going to give fluids. If this BUN creatinine is less, the ratio is less, we saw how bad the creatinine and all that stuff has to be for that. The idea is we're going to try this. Some of this is a little outdated. So for example, the dopamine doesn't really get done anymore. We're probably going to be given IB Lasix with some fluids to try to be like, here are the tools that you need to try to get all this flowing again. Hopefully it works. And this is something that I'm sure Ms. Brooks mentioned. If this is not responding to treatment, these are the things that can happen. So acidosis, electrolyte imbalances like we talked about, intoxication, drug toxicity, fluid volume overload, buildup of uric acid um, in the blood. And we mentioned that you have a high risk of fluid volume overload. So if you have a patient that is overloaded, what are the things you're looking for on them? What are you assessing on them for safety reasons? Physically or even like labs and stuff. So yeah, so we're gonna check for lung sounds because they could be drowning in fluid, so lung sounds. Just think about anything you can think about. If you hear patients overloaded, what are you going to do or assess? Imagine you're in clinical and having all this. So electrolyte labs, sure. And thinking about kind of their effects. So electrolyte labs and the effects of. We talked about lung sounds for pulmonary edema, general peripheral edema. Arrhythmias kind of goes with this part here. So arrhythmias and stuff. Um, how does the FBO affect some of their vital signs? Blood pressure. So yeah, we're gonna look at the blood pressure, the MAP, and try to take a look at how that is affected by all this. Bounding pulses, I like that, yeah. JBD, yeah. Yeah, weight gain. All of this stuff here is stuff to think about. And now this is interesting for sure here, but I don't think it's tested on too highly. We one of the things you can do is like the urine specific gravity. Um, let me see if I can remember what the value for that is. It's like 1.001 to 1.05 or something like that. Let's see. Something like that. I think that's about right. Yeah. I don't ever recall needing to know it though, if I'm being honest, but yes. The main thing is that it's going to be a high number. High specific gravity. What does that entail? What does high mean? Is that concentrated, diluted urine? What do you expect? So if you are keeping everything in, what is coming out, what do you expect it to be? Do you expect the urine to be dark or light colored? On a kidney patient that's not able to pee, or it's struggling to pee, but when they do pee, yeah, dark. So it's very concentrated. which makes sense. Their BUN is high because it's stuck in the blood because it can't come out. But when it does come out, your body's still doing their best to get rid of all the stuff out there. So what does come out is going to be very dark, very concentrated. And that's what you would expect on a normal, like pre-renal sense. The intrarenal is, again, referring to internal damage now. Direct internal kidney damage. So this is like one of her fun facts. I think Miss Brooks was an ICU nurse, so she got to nerd out about it. You don't really need to know this for test, if I'm being completely honest here. Your specific gravity can show the number 1.01, which is the specific gravity of plasma. Essentially, this is basically showing you that the kidneys can no longer even concentrate the urine. It's just the specific gravity of your plasma without any manipulation. Your kidneys could not even act upon it because they are not functioning. So it just gives you the base specific gravity of plasma. Does that make sense? Again, you don't really need to know it, but that's like the fun fact. So when your kidneys are functioning, you will have that specific gravity that could be variable, could be high, could be low, could be within range. When your kidneys are not working, you can see this number very specifically because there was no action done on the plasma by the kidneys because the kidneys are that impaired. Make sense? Okay. But again, it's extra. You have what's called a diuretic phase. So essentially your kidneys, which were damaged and impaired, start to work again, and now they're kind of overactive. So this is a good thing, actually. It's a sign that the kidney is healing. Um, but there is a lot of urine output. It's probably not going to be well concentrated. So you're making a good amount, but it's all really diluted. And because you're peeing so much, you really have to make sure that they don't go back into oliguric. Is this where they are considered a dry patient? So wet versus dry is referring to dialysis. So a wet patient is referring to pre-dialysis. The dry patient is referring to post-dialysis. This is essentially just the phases of your acute kidney injury. So at the start, it's impaired, so you don't make much urine. Then it's recovering, so your kidneys are now getting back on the job, and it's almost like they're making up for lost time. So they are hyperactive. They are just making urine, making urine, making urine, not really concentrating stuff too much, but they're just constantly making urine. Um, the way I think of it is like the kidneys are able to make urine again, but they're still kind of struggling to concentrate things. So they make up for the lack of concentration by just making a lot more urine. But it's a sign that your kidneys are healing because at least they're actually doing something now. So good quantity, poor quality. But because now they're peeing so much, that means they're also getting rid of a lot of fluid, which means if it's not managed or compensated for, it could go back into the oliguric phase. So in this scenario, you're gonna want the patient to probably be on IV fluids, even though that might sound contradictory to like the kidney patient. The fluids are there because the patient is in the diuretic phase, and they're losing a lot of fluids, and their kidneys are still healing and stuff. So that's something to keep in mind. So in general, when you have IV fluids on a patient, you want to think about why are they getting the IV fluids? Does it make sense for them to get IV fluids? Is the rate okay? Do they have congestive heart failure and they're getting IV fluids? You might want to be like, okay, but how are they tolerating it? How are their lung sounds? Or if you have this kidney patient, or how are they tolerating it? Why are they getting fluids? Usually, if they usually be on a fluid restriction, but they're not on a fluid restriction, so why are they getting fluids? You can look into it a bit deeper. You find out it's because they are recovering from an AKI and they're in the diuretic phase. So then your next thing to think about is, are they actually still in the diuretic phase? How are their numbers looking like? Because you are going to make a gradual return to normal, so you also got to think about um, now that they're starting to get past the diuretic phase, are those IV fluids now too much? Because there's again that kidney patient, so are we drowning them in peripheral in pulmonary edema again? So this came up for me. I had a patient that had chronic kidney disease. They had just recovered from an AKI. The reason that they were on IV fluids, I think they were on 70 ml per hour IV fluids. The reason they were on it was because the nephrologist wanted it because the patient was in the diuretic phase, but in the day of care, the patient wasn't necessarily like having overactive urination. Their urine output was like pretty normal. It wasn't extra. They weren't they weren't like constantly peeing, and the look of the urine didn't look diluted. Um, so they were probably out of the diuretic phase. Um, and now those IV fluids that they had to originally make up for it was actually starting to become crackles in the lungs. So that's where you have to do the critical thinking, and always question yourself on that kind of stuff. Because remember, you're the one looking at the patient. The doctor just kind of gets report from you. So if you're just saying, doctor said it's for diuretic phase, therefore it's fine, and then you don't assess properly, you're going to be missing out on that information. Does that make sense? Anyone confused? Yes, no? Okay. So for the most part, a lot of the stuff you'll see in chronic kidney disease is a lot of the stuff you'll see in acute kidney injury as well. But of course, it's chronic as opposed to being acute. So some of these things are still going to be roughly the same. So we talked about the normal GFR. That's going to be 85 to 125. And again, the eGFR is an estimation. Your GFR and your creatinine clearance are effectively the same thing. But when I say GFR, I mean actual GFR, not eGFR. So creatinine clearance is your glomerular filtration rate, but the eGFR is an estimation and is not the same thing. I know that's confusing. I've listed the different types of stages. You don't really have to hard memorize it. You really don't. But here you can kind of see the progression happening. So this is normal. Stage one, you're still almost within that normal range. And then as you go down and down, um, it gets worse and worse. So it's stage 1 to 4, and then end stage renal disease is the thing after. And a lot of the time, people with ESRD are going to not make urine, but there are people that still are making urine. So just keep that in mind and make sure you're checking up on that. The manifestations and assessments are going to be the same. So you guys already kind of went over that. So that's good. And I do have this picture that I like that kind of goes over all the stuff you'll see with chronic kidney disease. So what kind of going from here, anemia, we talked about how that how the kidneys being affected. Deal with that. Musculoskeletal, the cramps, bone pain. We talked about how the calcium impacts the bone pain, cramping due to changes in electrolytes. The skin issues, I imagine are due to, I know that you can have pruritus, so that's itchiness. Your phosphate buildup, your magnesium buildup can lead to itchy skin. And some of these people will get like phosphate binders and stuff like that, and that can help. I've also read up on the use of certain SSRIs, which are normally used for anxiety or depression, that can actually be used to help with the itching. Um, is So let me see why this general skin. Oh, just due to toxin buildup, and poor perfusion. So you have dry skin. That makes sense. The neurological kind of goes again with FBO and electrolyte imbalances, cardiovascular, perfusion issues leading to cardiovascular stuff, pulmonary due to FBO. So all of these due to FBO, the GI issues, due to electrolyte imbalances. Again, just general buildup of waste product in the blood and stuff like that. Okay. Any questions so far? Because I know chronic doesn't get as much look over because it's got a lot of the same assessments and manifestations. There is some stuff here though that we can add on that we can kind of go over. Try not to take too much time here.
I have a question.
Yeah.
For azotemia, is that just a word for saying that all of the labs are jacked up? Or is that
Yeah. Azotemia is usually related to like nitrates.
mm-hmm.
So it would mean that like nitrogenous waste products, so like urea and nitrogen buildup essentially.
And can that happen in the oliguric phase and the diuretic phase?
So with the buildup of urea and creatinine, I think it would be more in the oliguric phase because that's when you're fully unable to make urine really or having a really hard struggle, so the buildup happens. Um, in diuretic, you're it's going to be improving because you're going to be peeing it out more. It's not going to be as concentrated, so but you are making that slow progression down to like normal. But that's azotemia just means like increased urea and creatinine and stuff like that.
Okay. Okay, thank you.
Hmm. I guess just to make it more interactive again, what are some things you would do for this patient or avoid, or things for diet related things that you would do for ESRD or just a chronic kidney disease patient? What kind of meds do you possibly expect them to be on, etc.? Yeah, they would be on some diuretics. So diuretics, you just got to be really careful with it because they can also lead to even more damage. But it's kind of like you kind of have to do like the risk versus reward. So fluid retention can help. Waste K and mag. Restrict protein. Yeah. So this is the renal diet, which is terrible. Terrible. It includes protein restriction. What else do you guys think it includes? Yeah, you have a sodium restriction, protein restriction, pretty much, yeah, potassium restriction, phosphate restriction, magnesium restriction, everything restriction, honestly. It's hard to say. It's really difficult in terms of like carbs. You definitely have a fluid, you have a water restriction as well. It's difficult to say because here's something else that occurs with hypoglycemia is that they also have a harder time um, with like insulin stuff. So these people have to be assessed for hypoglycemia because insulin is held on for longer in the body. So if they have too many carbs at once, it could lead to this like a high release of insulin, and then it stays in the body, and then their blood sugars are low. So it's such a hard thing to manage, if I'm being honest. It would still be like your main source, but I would say it's difficult. It has to be like your moderate. It has to be like a moderate. Just be spaced out properly because of this feature. So a lot of carbs at once, lots of insulin gets released, but because their kidneys don't work as well, kidneys are going to be one of the way alongside your liver that are going to help to metabolize and kind of make the insulin go away. So it'll stay longer in your body if it's not working properly. So then you'll be hypoglycemic. So it's really difficult. So once your kidneys kind of go, it gets really hard. And things to avoid. We've been talking about nephrotoxic medications. Something random, antacids, because they have magnesium a lot of the time. And Demerol, which is a opioid that builds up toxic, has like a little toxic thing that it like when it breaks down in your body, it leads to like a uh toxic compound, and then it builds up in your body a lot more worse because you have kidney disease. Okay, I talked about phosphate binders, so I'll give you guys some examples of some. Calcium acetate. This is called Foslo. This one has to be taken with food so that it binds to the food. So you might see someone with kidney problems on calcium acetate and then also on calcium chloride, I think, just so that they might need that for calcium replenishment and also the calcium acetate to bind to the phosphate in the food. So stuff like that. And like I mentioned, can also help to decrease itchiness. Like we talked about azotemia. Azotemia also deals with the urea. So anytime you have urea, allopurinol. And something that's we talked about with the liver was if the liver is not working right, then you have buildup of ammonia, which causes confusion. Um, so that's why we want the liver to break down the ammonia into urea. But then also, if we have too much urea, that also leads to confusion. So both of those kind of suck. We also talked about erythropoietin, poietin, epogen, some vitamin D supplementation, and then of course, well, iron and folic acid. Iron to treat anemia or vitamin B12, and of course, antihypertensive and hypertension meds. They'll probably be on like 3 to 5 at once. Medications, well, more I could say prescribed at once. Probably space it out a little bit. Um, but yeah, if you have a patient that is on like 5 antihypertensives, how do you go about giving it? You can try to space it out. You can also just ask them directly, how do you take these at home? Because if he's fine taking all of them at once at home, never had an issue with the blood pressure, then you kind of already know this is how he'd been doing it. So you can save yourself the trouble. Or if he tells you, I take these 3 at once, and then I wait a little bit and then take the other 2 together. That way you kind of have an idea of how the meds are to be given. Any questions so far? I know there's a lot of material here. It's been about 2 hours. We're almost done though. Dialysis is honestly not that long, genuinely. And she didn't really emphasize it in her lecture, and I was told to emphasize it a little bit. Um, oh, that would be for dialysis, so we'll talk about that with dialysis. So this is just for chronic kidney disease right now. So these right now, we're gonna give them. Holding it is due to dialysis because of the whole process of dialysis is you're basically taking their blood. They're taking their blood and getting rid of the waste and then putting it back in. Okay. Yeah, I think she told me to go a bit more detail into dialysis because she didn't get to do that with you guys, but it's really not a huge focus, genuinely. So we'll just go over the basics and the important stuff because again, it's really not all that crazy on that. Let me see exactly what she said. Swear I just saw this. Where is it? Oh, there it is. Okay, she just wanted dialysis and care of the dialysis patient. Okay. So this is pretty much what I got here. The definition here kind of explains it. You don't need to know how it physically works. Don't really worry about it. Here's when it's typically done, but again, it's really not tested on the higher super specifics. The main thing you really want to focus on is your considerations, your complications, um, and that's really your focus on. When you have dialysis, patients usually going to have like an AB fistula. Um, so let's take a look at what that looks like. AB fistula / graft. So something like that, not really is pretty common. You're going to want to know what side it's on because you're not going to want to, holy crap, what's that? Because you're not going to want to do blood pressures on that arm. Oh, wow. Wow, okay. Okay. Yeah, so this is stuff that you might have seen in clinical. So again, what are our in terms of like the patient with dialysis, let's say they tell you they have an AB fistula on their left arm. What are things you are assessing on that AB fistula? The bruit and the thrill, exactly. So how do you do that? So which one's the bruit, which one's the thrill? Just so you don't get caught up by semantics. Yeah, the thrill is the vibration, so we're going to palpate for thrill. Is a vibration. And we're going to listen to the bruit. We're going to auscultate the bruit. And it'll be like a pretty loud little whooshing sound. That's pretty much all you really got to do with that. Just make sure that it's good. Like I mentioned, you're not going to want to do blood pressure or lab draws on that arm that has the AV fistula. And what are you assessing for physically on it? Like, what are you looking at? We kind of saw some pictures of it. Well, just kind of casually looking at it here. Yeah, clots, impaired perfusion on it. And it's something that you are going in and out of. So infection, you're going to be assessing for signs of infection. Okay, so then for considerations, does the patient have to be MPO when they're getting dialysis done? No, yeah, they do not have to be MPO. Patient does not have to be MPO. Do we have to hold their insulin on this patient? Can we give insulin while they're getting dialysis? They're chilling in the dialysis room and or they're getting in-room dialysis. So is that saying, are you guys saying we do give insulin or we don't give insulin? We do give, yes, correct. So we can do AccuChecks and we can do insulin. What about, yes, so you want to hold the BP medication. So hold BP medications. Why? Because they're about to have their blood exit their body, um, get cleaned and then come back in. So there are a risk of them going way too low in their blood pressure with the dialysis if you do not hold the blood pressure medication. So that is important. So that is why you have a patient with um, that gets dialysis. You need to know their schedule. You need to know if they're going for dialysis that day. You need to make sure you are aware of their plan of care. Maybe there's an update on their on dialysis schedule. I had a patient that was scheduled for dialysis. Don't remember the dates, but it wasn't supposed to be on that day. But then because the patient wasn't able to, one of the reasons they came in is because they weren't able to get dialysis for a few days. So they missed a few sessions already and they weren't due until like the next day. But the doctor changed the plan of care so that it was okay, we're gonna get dialysis done today. So it was important for us to hold the blood pressure medications so that they can get to their dialysis that day. So that's the most important thing here. And remember, this only, of course, applies to dialysis. We're definitely not going to do that for normal routine when they're not getting dialysis on these patients because they need their blood pressure medications. So some of the complications here you're going to look at is going to be kind of changes in their fluid balance. So Anne was talking about the wet weight versus the dry weight. So wet weight is referring to their weight before dialysis, and dry weight is going to be after dialysis. And it's worth noting, again, back from like your math stuff, that you have 1 kilogram is equal to 1 liter of fluid. So that's kind of what you want to think about with that. What else are you doing to kind of monitor the fluid balance? There's going to be electrolyte changes, yes, and we'll talk a little bit about that as well. So what else? How do you know if there's a change in their condition other than like physical? What else can you do to have like a baseline? Daily weight. So other than daily weights, what else? Sure, lung sound. Sure. What else? Something you guys do every day at clinical, or someone does it every day at clinical, multiple times a day. Sure, physical assessments on all that, blood pressure, vital signs, basically. Vital signs before and after. And then reason for that is because we're giving them dialysis, their blood pressure can already dip down. Maybe we need something to stabilize the blood pressure. So we need to know what their baseline is so that we know when there's a huge relevant change. So it can lead to hypotension because, of course, they're getting all this stuff and fluid electrolyte shifts, like we mentioned, but that's where we talk about something else. Sugar levels, potentially, yeah. So obtain baseline and determine if we need to stabilize BP, so hypotension. Okay. Then you guys also mentioned electrolyte imbalances. So there's something called the disequilibrium syndrome. Spelled syndrome wrong. So this is due to the rapid exchange of electrolytes due to dialysis. So some people can have bad reactions to dialysis. This can lead to altered level of consciousness, nausea, vomiting. The reason I'm not really asking you guys too much about this is just because we don't get directly tested on it, but it's good to know. At least you don't get, I don't think you get like any select all that applies on signs and symptoms, but you can kind of see how these are very similar to the stuff we talked about with electrolyte imbalances in the first place. Up above, we talked about potassium and sodium imbalances. We talked about a lot of these signs and symptoms. When you have massive giant fluid shifts, you have increased ICP. So you have all of this leading to increased ICP. So what do you do about it? The only thing I think you do need to know about this equilibrium syndrome is kind of like how do you act when this is what you're seeing? What can you do? Okay, that's good. These are all good. So this is gonna be someone that's like quickly deteriorating. So call a rapid. Yeah, I like call a rapid or MD, probably the rapid. And try to do your best to like head of the bed up, O2 supplementation. Obviously you're taking the vital signs. So you're seeing all this happen, you're gonna probably take the vitals first. Based off that, you're gonna call a rapid and then do your best with what you can to try to fix the vitals. This is it's probably gonna be I mean to be fair, this is mostly like fluid shifts. So the electrolytes will probably be somewhere from normal to probably somewhere like it might not even be like like the electrolyte themselves are abnormal. It's just that the fact that they all left at once caused massive fluid shifts, and then all those fluids went to the brain. Essentially, the fluids went to the cells in the brain. So their electrolytes themselves could be could be kind of whatever, but it's just like the fluid shift. So the idea is, if anything, I would probably venture on the lower end. So the idea is you have, if you guys recall from 212, you have all this your water goes to wherever your solutes are. So in this moment, you have a lot of solutes in your blood, so the fluids stay like in your vessels. If you were to suddenly lose a bunch of the solutes in the blood, now all of a sudden the cells have more solute, so the fluids rush to the cells. So in this case, that is what's causing increased ICP, and then that is what's causing the issues with most of the stuff here. So you do have a lot of these like electrolyte stuff happening as well, but the main thing here is the shift in fluids. And really the main thing you want to think about is just how to intervene, which a lot of the time includes your vitals, calling a rapid if you feel like you can't do anything, and trying to stabilize with what you can. And like I said, you don't have to know details about disequilibrium syndrome, just kind of have like this general knowledge of how to intervene in case of stuff going down crazy. Next up, you can also have blood loss. Something to note is that the patient should be on a heparin drip. to prevent clotting during dialysis. But if they're on a heparin drip, that also means they have a risk of losing blood. And then lastly, again, you're accessing something inside internal, so risk of infection. I'll probably highlight this as well. Questions? So just to kind of reiterate again, your things you're looking at is you're assessing the AV fistulas and grafts to make sure that it's actually patent for the thrill and the bruit. You're going to make sure not to put a blood pressure cuff or try to get lab draws on that arm. You're going to assess for clots. We saw this picture right here, some engorgement and all this other stuff happening over there. And it's an IV axis. It's like an IV axis basically. So infection because it's internal, it's invasive. The considerations are really important, especially the fact that you have to hold blood pressure medication. That's going to be like your main thing. Like, don't really stress too much about what other things need to be held. Really, they're going to really focus on the priority, which is the blood pressure. And then for the complications, really focus in on fluid and electrolytes, like we mentioned here. And then just keep in mind that they're on a heparin drip, so blood loss is possible. Lastly, we have peritoneal. So let's take a look at this picture. Peritoneal dialysis. This one, you can think of it like you have a little bit more independence because you can kind of set it up yourself. And it's going to happen just like the name says in the peritoneal cavity. And it's going to work off glucose concentration. So this bag is full of glucose. And it's through this dialysis solution that's going to go in here. And it's going to, the concentration of that is going to lead to shifts in um, like the fluid and the electrolytes, and that's how the dialysis works on that scenario. So you're still going to have dry versus wet weight. You're still going to want to take the blood pressure. You're still going to want to be aseptic because you're doing an internal thing. But just based off this sentence, what do you think you're also going to be monitoring more heavily? Because this is going to be going into their peritoneum. Peritonitis is definitely one of them. What about just based off this one sentence here? We're definitely going to assess for peritonitis, so that's a complication. Yeah. So this one's going to be a monitor blood glucose because the dialysis in this one is you're literally getting a sugar solution put inside of you. And that's what leads the exchange. So because you're putting glucose solution in you, you can kind of take a look here. You run the risk of hyperglycemia. So you want to monitor for your blood glucose because that's one of the things that can be affected by this one specifically. I will just tell you right away, I think your test really focuses more on hemo than peritoneal, but they will follow similar principles. You don't have an AB fistula because this is happening in your peritoneal. And so the real main differences is the blood sugar and the fact that it's in your peritoneal, so you can have peritonitis. What do you guys remember from peritonitis that is still relevant for this, like signs and symptoms that you can expect? And then, yes, hyperglycemia. Firm abdomen, yep. We'll say distended abdomen as well. We're gonna treat it with antibiotics. Pain, yeah. Imagine it's painful. Something that makes it pretty obvious is that the stuff that's coming out. So if you could take a look at this picture here, this is your solution of glucose that's going to be coming in here. This right here is what's basically going to be exchanged out. And you have this bag full of the output. If there's infection, what do you think that solution, the output is going to look like? Yeah, it's going to be cloudy or frothy. And let's take a picture of what cloudy actually looks like. Let's just use urine, but peritoneal fluid as well. This is what it's supposed to look like. This is what it looks like if it's cloudy. It literally means you can't see through it. Same thing with like urine, cloudy urine. It's gonna look like that. You can't see your finger on the other side. See that? You can't see through it. This one you can see through it partially. So that's what that means when they say cloudy. And then hyperglycemia, again, we said monitor blood glucose, and also you're gonna give insulin if needed. Which makes sense, right? If your blood glucose go up, give insulin. We mentioned other complications, painful abdomen, abdomen pain. You can have that even without the peritonitis, but this is like a minor, it's like a complication, but it's an easily fixable one. How do you fix this one? Or I'll add this. It could be related to high flow or position related. Just reposition, yeah. So if someone's having that abdominal pain complaint, um, you're going to assess like their drainage bag, of course, but you're also going to try to just reposition them first because that could be like it could be caused by the positioning or the flow as opposed to like peritonitis. So like you're gonna reposition them and then maybe see how if the bag is cloudy, check to see if they have firm abdomen. But at the very least, you fix the uh like you didn't go for like you went for like the most likely complication first, which is just repositioning before you went into further assessing for the more complicated one. And then this is pretty much the same thing. Problems with the flow, and you're basically just assessing for kinking. So again, it's reposition the patient. Reposition, relief pressure. Maybe they have to poop, which builds up pressure in the abdomen. But that's pretty much it. That's pretty much all you have to know about dialysis. It's really I'm glad she went over the other stuff with you guys in detail, supposedly, according to her. I'm not sure how much detail you guys felt like they went over, but just because that's a little bit more important. The dialysis, you'll have a few questions, but it's not in hyper detail, in my opinion. You really just focus on the most important stuff here. So BP, fluid balance, how to manage a major complication. So some of the basic stuff here, specifically with peritoneal, the blood glucose. Um, things like how do I know if it's an infection? So this firm abdomen is important to know because that's a common descriptor. Cloudy. What to do if you have um, issues with getting solution to come out. Getting solution to come out of here. It's probably a position based. If they're having pain, reposition first and then try to assess for the other stuff. It's always important to do vital signs before and after. Um, maybe you'll need to know how much fluid of approximately how much fluid they lost based on their changes in kilograms. So maybe you'll have to know how to convert from pounds to kilograms again. So 2.2 pounds is 1 kilogram. Okay. Any questions on renal? Okay, I'll give you guys the outline. Yeah, it is a lot of content and it's a lot of new stuff that hopefully you guys managed to have like a patient or two that had renal issues, so you kind of get forced to learn it a little bit. At the very least, your this week's content, the cardiac, is basically review almost entirely. So that will be a lot better. Yeah, ESRD, okay. So hopefully that definitely helps. And yeah, I'll end the recording here.